The preoperative period begins when the patient is scheduled for surgery and ends at the time of transfer to the surgical suite. Preoperative nursing places emphasis on safety, advocacy, and patient education. The patient readiness for surgery is critical to the outcome. Preoperative nursing focuses on preparing the patient for surgery and patient safety. This includes education and any intervention needed before surgery to reduce anxiety and complications and to promote patient cooperation in procedures after surgery. Prepare the patient for possible placement of tubes, drains, and vascular access devices. Preparation reduces the patient's anxiety and fear and the family's negative reaction. Tubes of all sorts are common after surgery. The patient may need an indwelling urinary catheter before, during, or after surgery to keep the bladder empty and to monitor kidney function. Drains are often placed during surgery to help remove fluid from the surgical site. Some drains are under the dressing, others are visible and require emptying. Inform the patient that drains are often used routinely and that generally they are not painful, but they may cause some discomfort. Vascular access is in place for patients receiving a general anesthetic and for most patients receiving other types of anesthetics. Access is needed to give drugs and fluids before, during, and after surgery. Patients who are dehydrated or who are at risk for dehydration may receive fluids before surgery. A nasogastric tube may be inserted before abdominal surgery to decompress or empty the stomach and the upper bowel. The tube is placed after the induction of anesthesia when insertion is less disturbing to the patient and easier to perform. Breathing exercises include deep or diaphragmatic breathing to enlarge the chest cavity and expand the lungs. For deep breathing, have the patient sit upright on the edge of the bed or in a chair. Make sure that their feet are placed firmly on the floor or on a stool. After surgery, deep breathing is done with the patient in a Fowler's position. Have the patient take a gentle breath through their mouth. Have the patient breathe out gently and completely. Then have your patient take a deep breath through their nose and mouth and hold their breath to the count of 5. Then have your patient exhale through their nose and mouth. For expansion breathing, have your patient find a comfortable upright position with their knees slightly bent. Bending the knees decreases abdominal tension on the abdominal muscles and decreases respiratory resistance and discomfort. Have the patient place their hands on each side of their lower rib cage, just above their waist. Have the patient take a deep breath through their nose, using their shoulder muscles to expand their low rib cage outward during inhalation. Instruct the patient to exhale, concentration first on moving their chest, then on moving their lower ribs inward while gently squeezing their rib cage and forcing air out of the base of their lungs. Incentive spirometry is another way to encourage the patient to take deep breaths. Its purpose is to promote complete lung expansion and to prevent pulmonary problems. There are various types of incentive spirometers available. With all types, the patient must be able to seal their lips around the mouthpiece, inhale spontaneously, and hold their breath for 3 to 5 seconds for effective lung expansion. Goals for attaining specific volumes are set according to the patient's ability and type of incentive spirometer. Coughing and splitting may be performed along with deep breathing every 1 to 2 hours after surgery. The purpose of coughing are to expel secretions, keep the lungs clear, allow for aeration, and prevent pneumonia and atelectasis. Splinting the incision area provides support, promotes a feeling of security, and reduces pain during coughing. A folded bath blanket or pillow is helpful to use as a splint. Cardiac patients may receive their own heart-shaped pillow for splinting. Older patients are at an increased risk for complications. The normal aging process decreases immune system functioning and delays wound healing. The frequency of chronic illnesses increases in older patients. In addition, reduction of muscle mass and body water increase the risk of dehydration. Medical history is important to obtain because many chronic illnesses increase surgical risk and need to be considered when planning care. Ask the patient specifically about cardiac problems. Cardiac problems that increase surgical risk include coronary artery disease, angina, myocardial infarction within 6 months of surgery, heart failure, hypertension, and dysrhythmias. Chronic lung problems such as asthma, emphysema, and chronic bronchitis also reduce the elasticity of lungs, which reduces gas exchange. As a result, patients with these problems have reduced tissue oxygenation. A sensitivity or allergy to certain substances alerts the nurse to a possible reaction to anesthetic agents or substances that are used before or during surgery. For example, providone iodine, better known as betadine, used for skin cleansing, contains the same allergens found in shellfish. Patients who have an allergy to shellfish may have an adverse reaction to providone iodine or betadine. The patient with an allergy to bananas and other fruits may also have a latex sensitivity or allergy. Discharge planning is started before surgery. Assess the patient's home environment, self-care capabilities, and support systems, and anticipate post-op needs before surgery. All patients, regardless of how minor the procedure or how often they have had surgery, should have discharge planning. Older patients and dependent adults may need transportation referrals to and from physicians' offices or the surgical setting. A home care nurse may be needed to monitor recovery and to provide instructions. All patients with few support systems may need follow-up care at home. Some patients need a planned direct admission to a rehabilitation hospital or center for physical therapy after surgery, especially joint replacement surgery. Shortened hospital stays require adequate discharge planning to achieve desired outcomes. Specific considerations when planning care for older preoperative patients are: there is a greater incidence of chronic illness, a greater incidence of malnutrition, they have more allergies, increased incidence of impaired self-care abilities, inadequate support systems, decreased ability to withstand the stress of surgery and anesthesia, increased risk for cardiopulmonary complications after surgery, risk for change in mental status when admitted related to unfamiliar surroundings, change in routine and drugs, and of course increased risk for a fall and resultant injury. Surgeries may be performed for a variety of reasons. Diagnostic surgery is performed to determine the origin and cause of a disorder or to determine the cell type for cancer. Examples are breast biopsy, an exploratory laparotomy, or even an arthroscopy. Curative surgery is performed to resolve a health problem by repairing or removing the cause. Example is a cholecystectomy, which is the removal of gallbladder, an appendectomy, or even a hysterectomy. Restorative surgery is performed to improve a patient's functional ability. A total knee replacement or a finger reimplantations are examples. Palliative surgery is performed to relieve symptoms of a disease process but does not cure. Examples are a colostomy, nerve root resection, tumor debulking, or an ileostomy. Cosmetic surgery is performed primarily to alter or enhance personal appearance, such as liposuction, revision of a scar, or a rhinoplasty, better known as a nose job. Surgery also may be classified according to the degree of urgency involved. Elective surgery is planned surgery for correction of a non-acute problem such as cataract removal, hernia repair, hemorrhoidectomy, or a total joint replacement. Urgent surgery requires prompt intervention, may be life-threatening if treatment is delayed more than 24 to 48 hours. Examples of urgent surgery may include intestinal obstruction, a urinary bladder obstruction, kidney or renal stones, bone fractures, eye injury, or acute cholecystitis. Emergent surgery requires immediate intervention because of life-threatening consequences, such as a gunshot or stab wound, severe bleeding, abdominal aortic aneurysm, a compound fracture, or an appendectomy. Surgery is also classified in terms of the amount of risk involved. Minor is a procedure without significance, often done with local anesthesia, such as an incision and drainage of a wound, an implantation of a venous access device, or a muscle biopsy. A major surgery is a procedure of great risk, usually longer and more extensive than a minor procedure, such as a mitral valve replacement, a pancreas transplant, or possibly a lymph node dissection. Finally, the surgical procedure may be classified as to the extent of surgery. Simple means only the most overt affected areas involved in the surgery. Simple partial mastectomy are examples. Radical is more extensive surgery beyond the area obviously involved. It is directed at finding a root cause. Examples are a radical prostatectomy or a radical hysterectomy. Minimally invasive surgery is surgery performed in a body cavity or body area through one or more endoscopies. This type of surgery can correct problems, remove organs, take tissue for biopsy, or even reroute blood vessels. This type of surgery is a fast-growing and ever-changing type of surgery. Examples include an arthroscopy, tubal ligation, a hysterectomy, a lung lobectomy, coronary artery bypass, or cholecystectomy. Before surgery, the patient is expected to have manageable anxiety as indicated by expressing a reduced level of anxiety, showing an absence of body language that indicates anxiety. Interventions such as teaching and communicating with patient before surgery hopefully will enable the patient to use previous successful coping mechanisms, and giving anti-anxiety drugs helps to reduce anxiety. Also, incorporating available support systems into the plan of care and teaching the spouse and significant others may indeed help the patient. Preoperative teaching involves first assessing the patient's knowledge about the surgical experience and then providing factual information to promote the patient's understanding. Allow ample time for questions. The informed, educated patient is better able to anticipate events and maintain self-control and is thus less anxious. Encouraging communication by having the patient state feelings, fears, and concerns can help reduce anxiety. Keep the patient informed by clarifying information, answering questions, and allaying fears about surgery. Promoting rest is helpful because the stress and anxiety of impending surgery often interfere with the patient's ability to sleep and rest the night before surgery. The surgeon may prescribe a sedative or a hypnotic drug to help the patient be well rested for surgery. Distraction may be used as an intervention for anxiety, especially in the 24 hours immediately prior to surgery. Listening to music may decrease anxiety, or visiting with family members. Teaching family members helps reduce anxiety by increasing the likelihood of support and involvement in the patient's care. Assess the readiness and desire of the family to take on an active part in the patient's care. Family members can encourage and help the patient practice exercises to be performed after the surgery. Most families are anxious about the surgery planned for their loved one. To reduce their anxiety, explain the routine expected before, during, and after surgery. Tell the family that after the patient leaves the hospital room or admission area, there's usually a 30 to 60-minute preparation period in the operating room or in the holding room treatment area adjacent to the surgical suites. After surgery, the patient is taken to post-anesthesia care unit, better known as PACU or PACU, for at least 1 hour before returning to the hospital room or discharge area. Tell the family about the best place to wait for the patient or surgeon according to the facility's policy and the physician's preference. Many hospitals and surgical centers have a surgical waiting area so that families can wait in comfortable surroundings and be easily located when the procedure is complete. The skin is the body's first line of defense against infection. A break in the barrier increases a risk for infection, especially for older patients. Skin preparation before surgery is the first step to reduce the risk of surgical site infection. 1 or 2 days before the scheduled surgery, the surgeon may ask the patient to shower using an antiseptic solution. If the patient is hospitalized before surgery, showering are repeated the night before or the morning before transfer to the surgical suite. This cleansing reduces contamination of the surgical field and reduces the number of organisms at the site. Factors that predispose to wound contamination and surgical site infection include bacteria found in hair follicles, disruption of the normal protection mechanism of the skin, and nicks in the skin. Shaving of hair creates the potential for infection. Hair clipping with electric clippers and depilatories should be used for hair removal. The Centers for Disease Control and Prevention, CDC, recommends that if shaving is necessary, the hair should be removed using disposable sterile supplies and aseptic principles immediately before the start of the surgical procedure. If needed, shaving is performed in the treatment room, the holding area of the operating suite, or the operating room itself. Preoperative drugs may be prescribed regardless of the type of planned anesthesia. Various drugs reduce anxiety, promote relaxation, reduce nasal and oral secretions, prevent laryngospasms, reduce vagal-induced bradycardia, inhibit gastric secretions, and decrease the amount of anesthetic needed for the induction and maintenance of anesthesia. Drug selection is based on the patient's age, physical and psychological condition, medical history, height, weight, and other drugs the patient routinely takes, test results, and the type and the extent of planned surgical procedure. Data collection about the patient before surgery begins in various settings, such as the surgeon's office, the pre-admission or admission office, the inpatient unit, or even a telephone interview or a computer questionnaire. Data collected includes age, use of tobacco, alcohol, or illicit substances, such as marijuana, current drugs, use of complementary or alternative practices, such as herbal therapies, folk remedies, or acupuncture. Drug and substance use may affect patient responses to surgery. The use of tobacco increases the risk for pulmonary complications because of changes it causes to the lungs and chest cavity. Excessive alcohol and illicit substance use can alter the patient's response to anesthesia and pain medication. Withdrawal of alcohol before surgery may lead to delirium tremors. Prescription and over-the-counter drugs may also affect how the patient reacts to the operative experience. Medical history is important to obtain because many chronic illnesses increase surgical risks and need to be considered when planning care. Ask the patient specifically about cardiac disease because complications from anesthesia occur more often in patients with cardiac problems. The risk for myocardial infarction during surgery is higher in patients who have heart problems. Pulmonary complications during and after surgery are more likely to occur in older patients, those with chronic respiratory problems, and smokers because of smoking or age-related changes. Increased chest rigidity and loss of lung elasticity reduce anesthetic excretion. Chronic lung problems such as asthma, emphysema, and chronic bronchitis also reduce the elasticity of the lungs, which reduces gas exchange. As a result, patients with these problems have reduced tissue oxygenation. Adverse effects can occur with the use of some herbs such as black cohosh, garlic, ginseng, and licorice, to name a few. Previous surgical procedures and anesthesia affect the patient's readiness for surgery. Previous experiences, especially complications, may increase anxiety about the scheduled surgery. Blood donation for surgery can be made by the patient, which is an autologous donation, a few weeks just before the scheduled surgery date. Then, if the blood is needed during or after the surgery, an autologous blood transfusion can be given. This practice eliminates transfusion reactions and reduces the risk for acquiring blood-borne disease. Patients may wish to have family and friends donate blood exclusively for their use, if needed. This practice, called direct blood donation, is possible only if the blood types are compatible and the donor's blood is acceptable. All patients, regardless of how minor the procedure or how often a patient has had surgery, should have discharge planning. Shortened hospital stays require adequate discharge planning to achieve the desired outcomes after surgery. The preoperative patient may be any age, with a health status that varies from well to debilitated. Performing a complete assessment before surgery to obtain baseline data is important. During the assessment, identify current health problems, potential complications related to anesthesia, and possible complications that may occur after surgery. When beginning the assessment, obtain a complete set of vital signs. Abnormal vital signs may require postponing of surgery until the problem is treated and the patient's condition is stable. Also assess for anxiety, which could increase blood pressure, pulse, and respiratory rate. Report any abnormal assessment findings to the surgeon and to anesthesia personnel. Cardiovascular status is critical to assess because cardiac problems may cause as many as 30% of surgery-related deaths. Check the patient for hypertension, which is common, is often undiagnosed, and can affect the response to surgery. Cardiac assessment includes listening to heart sounds for rate, regularity, and any abnormalities. Examine the patient's hands and feet for temperature, color, peripheral pulses, capillary refill, and edema. Respiratory status: consider age, smoking history, including exposure to secondhand smoke, and any chronic illness. Observe the patient's posture, respiratory rate, rhythm, and depth, overall respiratory effort, and lung expansion. Document any clubbing of the fingertips or cyanosis. Auscultate the lungs to assess for any abnormal breath sounds. Kidney function affects the excretion of drugs and waste products, including anesthetics and analgesic agents. If kidney function is reduced, fluid and electrolyte balance can be altered, especially in older patients. Ask about problems such as urine frequency, dysuria, nocturia, difficulty starting urine flow, and oliguria. Ask the patient about the appearance and odor of their urine. Neurologic status includes the patient's overall mental status, level of consciousness, and orientation and ability to follow commands. The National Patient Safety Guidelines requires that you ensure patient safety by assessing the patient's risk for falling, especially the older patient. Evaluate factors such as mental status, muscle strength, steadiness of gait, and sense of independence to determine patient's risk. Musculoskeletal problems may interfere with positioning during and after surgery. For example, patients' arthritis may be able to assume surgical position but have discomfort after surgery from prolonged joint immobilization. Other anatomic features, such as the shape and length of the neck and the shape of the chest cavity, may interfere with respiratory and cardiac function or require special positioning during surgery. Nutritional status, especially malnutrition and obesity, can increase surgical risk. Surgery increases metabolic rate and depletes potassium, vitamin C, and B vitamins, all of which are needed for wound healing and blood clotting. In malnourished patients, decreased serum protein levels slow recovery. Negative nitrogen balance may result from depleted protein stores. This problem increases the risk for skin breakdown, delayed wound healing, possible dehiscence or evisceration, dehydration, and sepsis. Some older patients may have poor nutrition because of chronic illness, diuretic or laxative use, poor dietary planning or habits, anorexia, and lack of motivation or financial limitations. Indications of poor fluid or nutritional status include brittle nails, muscle wasting, dry or flaky skin, decreased skin turgor, hair that is dull, sparse, and dry, orthostatic hypotension, decreased serum levels, and abnormal serum electrolyte values. The obese patient is often malnourished because of an imbalanced diet. Obesity increases the risk for poor wound healing because of excessive adipose tissue. Fatty tissue has few blood vessels, little collagen, and decreased nutrients, all of which are needed for wound healing. Obesity stresses the heart and reduces the lung volumes, which can affect surgery and the recovery. Perform a psychosocial assessment to determine the patient's level of anxiety, coping ability, and support systems. Most patients have some degree of anxiety before surgery. Others may be fearful. Surgery may be seen as a threat to life, body image, self-esteem, self-concept, or even their lifestyle. Patients may fear death, pain, helplessness, a change in role or work status, a diagnosis of life-threatening conditions, possibly disabling or crippling effects, or of the unknown. Venous stasis leading to thromboembolism, VTE, a group of disorders that include deep vein thrombosis and pulmonary embolism, are potential but avoidable complications of surgery. These problems can lead to pulmonary embolism if the blood clot breaks off and travels to the lungs. Patients at great risk for VTE are listed on this slide. Always assess for VTE before surgery. Sudden swelling in one leg is a common physical finding of a VTE. A patient may feel a dull ache in the calf area that becomes worse with ambulation. All patients should be evaluated for VTE risk based on history, type and duration of surgery, and expected time of immobilization after surgery. VTE prophylaxis may involve devices and drug therapy depending on specific patient's evaluated risk. Devices may be used during and after surgery, along with leg exercises and early ambulation to promote venous return. Specific interventions depend on the patient's risk factors. Anti-embolism stockings and elastic wraps provide graduate compression of the legs starting at the end of the foot and ankle. Pneumatic compression devices enhance venous blood flow by providing intermittent periods of compression on the legs. Leg exercises also promote venous return. Teach leg exercises such as with patient lying in bed and in a Fowler's position. Have the patient bend a knee, raise their foot off the bed, and hold the position for a few seconds. Then have the patient extend their leg by unbending their knee and lower their leg to the bed. Repeat sequence 4 times with each leg. A second exercise is to have the patient point their toes towards the bottom of the bed, then point their toes towards their face. Repeat 4 to 5 times with each foot. Third exercise to teach your patient is to have your patient make circles with their ankles, first to the left and then to the right. Repeat 4 to 5 times with each foot. The fourth leg exercise is to have the patient bend their knee and push the ball of their foot into the bed or floor until they feel their calf and thigh muscle contracting. Repeat 4 to 5 times each leg. Mobility soon after surgery has many cardiovascular and other benefits. It stimulates intestinal motility, enhances lung expansion, mobilizes secretion, promotes venous return, prevents joint rigidity, and relieves pressure. For most types of surgery, teach the patient to turn at least every 2 hours after surgery while they are confined to bed. Laboratory tests before surgery provide baseline data about the patient's health and help predict potential complications. The choice of laboratory tests before surgery varies among facilities and depends on the patient's age, medical history, type of anesthesia planned. The most common tests are listed on this slide. Urinalysis is performed to assess for abnormal substances in the urine such as protein, glucose, blood, or bacteria. If kidney disease is suspected, or if the patient is older, the physician may request other tests to determine the type and degree of disease present. Report electrolyte imbalances or other abnormal results to anesthesia personnel and the surgeon before surgery. Hypokalemia increases the risk for toxicity if the patient is taking digoxin, slows recovery from anesthesia, and increases cardiac irritability. Hyperkalemia increases the risk for dysrhythmias, especially with the use of anesthesia. A chest X-ray determines the size and shape of the heart, lungs, and major blood vessels and provides evidence of the presence of pneumonia or tuberculosis. It also provides baseline data in cases of complication. Abnormal X-ray findings alert the surgeon to potential cardiac or pulmonary complications. Heart failure, cardiomyopathy, pneumonia, or infiltrates may cause cancellation or delay of elective surgery. For emergency surgery, X-ray results assist the anesthesia provider in selecting anesthesia. Other imaging studies are based on patient need, medical history, and nature of surgical procedure. For example, a patient with back pain may have a CT scan or an MRI examination before spinal surgery to identify exact location of the problem. An electrocardiogram, ECG, may be required for all patients older than a specific age who are going to have general anesthesia. The age varies among facilities but is often between 40 to 45 years. An ECG may also be required for patients with history of cardiac disease or those at risk for cardiac complications. It provides a baseline information on new or existing cardiac problems such as an old myocardial infarction. Because the surgical experience is foreign to many people, focus on teaching the patient and family members. Teaching may begin in the surgeon's office for planned or elective surgery. Pamphlets, written instructions, and videotapes or DVDs may be given or sent to the patient. More teaching may occur when the patient has pre-admission testing. Some facilities hold classes before surgery for groups of patients or shows videos for those who are having the same or similar surgical procedure. A tour of the operating suite and post-anesthesia care unit may be included. National patient safety goals require that you provide information about informed consent, dietary restrictions, specific preparation for surgery, exercises after surgery, and plans for pain management to promote patients' participation and help to achieve the expected outcome. Surgery of any type involves invasion of the body and requires informed consent from the patient or legal guardian. The National Patient Safety Goals state that the patient deserves to be informed and involved in decisions affecting their health care. Consent implies that the patient has sufficient information to understand the nature of and the reason for surgery, who will be performing the surgery, and whether others will be present during the procedure, all available options and risks associated with each option, the risk associated with the surgical procedure and its potential outcomes, and the risk associated with the use of anesthesia. Informed consent is one way to help ensure patient safety. It helps protect patients from any unwanted procedure and protects the surgeon and the facility from lawsuit claims related to unauthorized surgery or uninformed patients. As a competent adult, it is the patient's right to refuse treatment for any reason, even when refusal might lead to death. For example, in the case of Jehovah's Witness, some patients will not accept blood transfusion because of their religious convictions. The surgeon is responsible for having the consent form signed before sedation is given before surgery is performed. You, as a nurse, are not responsible for providing detailed information about the surgical procedure. Rather, your role is to clarify facts that have been presented by the physician, dispel myths that the patient or family may have about the surgical experience. You verify that the consent form is signed, and you serve as a witness to the signature, not to the fact that the patient is informed. Patients who cannot write may sign with an X, which must be witnessed by two persons. In an emergency, telephone or telegram authorization is acceptable and should be followed up with written consent as soon as possible. The number of witnesses and type of documentation vary according to the facility's policy. In a life-threatening situation in which every effort has been made to contact the person with medical power of attorney, consent is desired but not essential. In place of written or oral consent, written consultation by at least two physicians who are not associated with the case may be requested by the physician. This formal consultation legally supports the decision for surgery until the appropriate person can sign a consent form. If the patient is not capable of giving consent and has no family, the court can appoint a legal guardian to represent the patient's best interests. Some surgical procedures, such as intraocular lens implants, sterilization, and experimental procedures, may require a special permit in addition to the standard consent. Surgical procedures that are site-specific, such as left, right, or bilateral, require patient identification before surgery. To ensure the correct site is selected and the wrong site is avoided, the site is marked by a licensed independent practitioner and, whenever possible, involves the patient. Before starting the operative procedure, facilities use a timeout procedure to verify the correct site. The perioperative nurse is in a position of ensuring these safety measures are again implemented immediately before the procedure is started. Regardless of the type of surgery and anesthesia planned, the patient is restricted to NPO status before surgery. NPO means no eating, drinking, or smoking. The exact amount of time a patient must be NPO before surgery is controversial. Patients, especially older adults, who fast for 8 or more hours may have imbalances of fluid and electrolytes and blood glucose levels. The American Society of Anesthesiologists recommends a reduced NPO time, 6 or more hours for easily digested solid food and 2 hours for clear liquid. A major problem is that these guidelines for duration of fasting have not been implemented universally. NPO status ensures that the stomach contains a limited volume of gastric secretions, which decreases the risk for aspiration. On the day of surgery, the patient's usual drug schedule may need to be altered. Consult the medical physician and the anesthesia provider for instructions about drugs such as those taken for diabetes, cardiac disease, or glaucoma, as well as regularly scheduled anticonvulsants, antihypertensives, anticoagulants, antidepressants, and corticosteroids. The physician may prescribe some drugs, including the over-the-counter drugs such as aspirin and herbal supplements, to be stopped until after the surgery. Other drugs may be given IV to maintain drug level in the blood. Drugs for cardiac disease, respiratory disease, and seizures and hypertension are commonly allowed with a sip of water before surgery. The patient with diabetes who takes insulin may be given a reduced dose of intermediate or long-acting insulin based on the blood glucose level, or may be given regular insulin in divided doses on the day of surgery. Bowel or intestinal preparations are performed to prevent injury to the colon and to reduce the number of intestinal bacteria. Evacuation of the bowel is needed when the patient is having major abdominal, pelvic, perineal, or perianal surgery. Enemas ordered to be given until return flow is clear is a stressful procedure, especially for the older patient. Repeated enemas can cause electrolyte imbalance, fluid volume imbalance, vagal stimulation, and postural hypotension. Enemas also cause severe anorectal discomfort in patients with hemorrhoids. Some physicians prescribe potent laxative such as Go Lightly instead of enemas, especially for older patients. Bowel preparations can be exhausting, and you must take safety precautions to prevent falls. Review the patient's chart to ensure that all documentation, preoperative procedures, and orders are completed. Check the surgical informed consent forms to see that they are signed and dated and that they contain the witness's signatures. Confirm that the scheduled procedure, including the identification of left versus right when necessary, is what is listed on the consent form. Even though it might be obvious, inform the patient that the area for surgery will be marked before the procedure begins. Document allergies according to facility policy. Accurate measuring and recording of height and weight are important for proper dosage of anesthetic agents. Ensure that the results of all laboratory, radiographic, and diagnostic tests are on the chart. Document abnormal results and report them to the surgeon and anesthesia provider. If the patient is an autologous blood donor or has directed blood donations made, make mention in the record. Report special needs, concerns, and instructions to the surgical team. For example, advise the surgical team if the patient is a member of Jehovah's Witnesses and does not accept blood products, or if the patient is hard of hearing and does not have his or her hearing aid. Facilities usually require the patient to remove most clothing and wear a hospital gown into the OR. However, underwear may be worn in above-the-waist surgery and socks may be worn except in foot or leg surgery. If prescribed by the surgeon, apply anti-embolism stockings or pneumatic compression devices before surgery. Patients are advised to leave all valuables at home. If he or she has valuables, including jewelry, money, or clothes, they are given to a family member or locked in a safe place, according to facility's policy. If rings cannot be removed, tape them in place. The patient wears an identification band that clearly gives the first and last name, hospital number and physician, and birth date. An additional bracelet identifies any allergies. A bracelet indicating that a blood sample for type and screen has been drawn may be worn also, depending on facility policy. If dentures are to be removed, including partial dental plates, place them in a labeled denture cup. Denture removal is a safe measure to prevent aspiration and obstruction of the airway. All prosthetic devices, such as artificial eyes and limbs, are removed and given to a family member or safely stored, as are contact lenses, glasses, wigs, and toupees. Check and remove hairpins and clips, which can conduct electrical current used during surgery and cause scalp burns. Some facilities allow hearing aids in the surgical suite to help communication before and after surgery. The removal of fingernail polish or artificial nails is controversial. Polish and artificial nails have been thought to affect accuracy of pulse oximetry readings. Recent studies have indicated that pulse oximetry readings taken on fingers are affected by brown or blue polish, but not by red or lighter colored polish. Most common drug categories given preoperatively are listed on this slide. Preoperative drugs may be prescribed regardless of the type of planned anesthesia. Various drugs reduce anxiety, promote relaxation, reduce nasal and oral secretions, prevent laryngeal spasms, reduce vagal-induced bradycardia, inhibit gastric secretions, and decrease the amount of anesthesia needed for induction and maintenance of anesthesia. Drug selection is based on the patient's age, physical and psychological condition, medical history, and height and weight. If more than one response is required, combination therapy may be prescribed. Preoperative drugs may be given when the patient is on call to surgical suite. After positively identifying the patient using the armband and asking the patient to state his or her name and date of birth, give the correct drugs in the correct dosages. Then raise the side rails, place the call light within reach of the patient, and remind him or her not to try to get out of bed. Place the bed in a low position. Tell the patient he or she may become drowsy and have a dry mouth as a result of the drugs. A more common practice is for preoperative drugs to be given after the patient is transferred to the operating room. This allows the surgical team and anesthesia provider to make one more accurate assessment and have last-minute discussions with a patient not yet affected by drugs. The surgeon may order a prophylactic antibiotic to be given right before or during surgery to reduce the risk of surgical infection. When needed, the antibiotic is given within 60 minutes before the incision is made.